good morning to all our audience, Professor Emeritus, Datin, Professors, Associate Professors, Doctor, ladies and gentlemen, and a very warm welcome to the Malaysian Society of Pharmacology and Physiology 34th Scientific Meeting, which will be held from today, July 15th to July 17th. My name is Yasin, and I'll be your host for this morning's opening ceremony from 8:45 a.m. to 9:15 a.m. Before I start, let us go through a couple of housekeeping items. This symposium is held in conjunction with the Malaysian Society of Pharmacology and Physiology Annual General Meeting. Members are reminded that the AGM will be held later today from 3:30 p.m. to 5:30 p.m. Attendance is by invitation and for members only. The second housekeeping point is attendance at this conference is eligible for MMA CPD points. For those who intend to log the CPD points, please remember to fill in the attendance sheet for each and every session. The link to the attendance sheet will be circulated in each session. Let me start by giving a short introduction to the Malaysian Society of Pharmacology and Physiology, in short, MSPP. MSPP started out as the Malaysian Society of Pharmacology and Experimental Therapeutics, or MSPAT, in 1976. The society was joined by physiologists as members and subsequently changed its name officially in 1988 to the Malaysian Society of Pharmacology and Physiology. MSPP membership now consists of pharmacologists and physiologists who are from academia and industry, and also medically qualified personnel and scientists from the health services. The society is recognized as the Malaysian Primary Learned Society of Pharmacologists and Physiologists, encompassing a broad spectrum of basic and applied pharmacology and physiology. MSPP plays a key role in promoting research among its members and has been organizing its own scientific meetings as a platform for researchers to share their research findings and build networking and collaborations. In the beginning, the MSPP scientific meetings were held biannually, but with increasing interest and support, the meetings have been organized annually. However, last year, due to the disruption of the pandemic, the MSPP 34th scientific meeting has been delayed to this year. The delay did not dampen the interest of the participants nor the members. It made them more eager and enthusiastic, gave them more time to prepare. So this year, with the waiver of registration fees under the goodwill of MSPP, the 34th scientific meeting held as the first virtual scientific meeting for MSPP witnessed a strong turnout of 700 registrants with the submission of 194 abstracts. Countries' borders may be closed because of the pandemic, but virtually this event has extended its reach and allowed like-minded scholars to meet and pursue their research and collaboration, even under the current trying times. MSPP is proud to inform that this virtual event has received submissions from Pakistan, India, Brunei, Bangladesh, and even submissions extending beyond this region to Saudi, Oman, Sudan, Mauritius, Nigeria, and UK. Currently listed on the MSPP program website are 74 video recorded oral presentations and 81 poster presentations categorized into 6 areas: cancer, cardiovascular disease, medical education and clinical practice, metabolic diseases, natural products and integrative medicine, and neurological diseases. Of this, 32 oral presentations and 48 poster presentations have been shortlisted for competition in a live presentation. This event will feature many interesting keynote and plenary lectures and symposiums, each with their latest research updates and new insights. Some of these sessions will take place concurrently. If you feel that you are torn between which symposium to attend, you do not need to despair. The sessions will be recorded and you will catch the different sessions even after the conclusion of the scientific meeting on July 17th. Without further delay, let me warmly welcome the President of the Malaysian Society of Pharmacology and Physiology, Professor Nafeeza Haji Muhammad Ismail, to provide her presidential remarks. Prof. Nafeeza is the immediate past dean of the School of Medicine at International Medical University, Malaysia. Prior to this, she was the Dean of Faculty of Medicine at University Technology Mara. She has held various portfolios at UITM as the Deputy Dean of Research, Deputy Chair, UITM Research Ethics and Committee, and the Head of Pharmacology at UITM. She was also the Chair and Board Member for the UITM Private Healthcare. Prof. Nafeeza is an active member of the American Society of Pharmacology and Experimental Therapeutics, the American Association of Advancement of Science, Malaysian Scientific Association, Malaysian Islamic Medical Society, and University Malaya Medical Alumni. Prof. Nafeeza and her team have worked tirelessly to implement activities to advance the objectives of the society and the professional goals of its members. Ladies and gentlemen, may I present Prof. Nafeeza.
Good morning, everyone. And for some of you, it's good afternoon or good evening, I'm sure. Thank you, Yasin, for the kind introduction. It is a great honor for me to be addressing this scientific crowd again as president of MSPP. This is the 6th time in my career that I have been the president. A great honor indeed, but beyond that, it's an even greater responsibility. I have first to express my highest appreciation to Dr. Farooq and his very able and efficient team for organizing this virtual conference. Looking at the program and the setup, Dr. Farooq and team have done an amazing job and must have had a lot of sleepless nights. I would also like to take this opportunity to extend a warm welcome to all and a virtual handshake to all speakers and all 700 participants. And I would also like to thank the speakers who have joined us virtually and taken time off their busy schedule. This year, I believe we have the highest number of participants, which is 700, since the birth of this society many years ago. We waived the registration fee for all as we acknowledge the impact of the pandemic on the revenue of certain institutions. But above and beyond that, it is to celebrate all of you scientists. The fact that we received so many abstracts shows that not only is the scientific community surviving, I must say it's really thriving. Let me show you the trend of attendees for the past 5 years. Although the surge in participants may be due to the fee waiver, some would say, I strongly believe that the society is gaining strength and momentum as we are visibly having a lot of activities. This year's attendance demonstrates an enormous burst of growth, and I believe this is the beginning of a new era for our society. And because of this, I want to extend a personal invitation to all participants who are not members yet to be a member of our society and encourage your colleagues and students, even undergraduate students, to join us. Because the good news is that we have grown significantly to become a society that offers many, many benefits to our members. We have, as you know, we have our annual scientific meeting. We are affiliated members of Asia Pacific Federation of Pharmacologists, FEOPS, International Physiological Society, and IUPHA, an International Pharmacology Society. We've also got webinars in the form of global lecture series, and it's free for members only, online webinars, community outreach for members to participate, and newsletter to keep members in touch to what we are doing and what's going on. And we also, of course, we also have a website. Young Teachers Award is an annual thing. Young Researchers Award is also an annual thing. And for the CPDs that we jointly conduct with our university, we give discount for members and many, many more. This is your society. Hence, we also welcome your ideas on activities. So bring your ideas to us and we'll work together. And if it benefits the society and the greater good, we will make it into a reality. This is what I was talking about, the Global Lecture Series. We've had one this year, and the first one was set in April, on the 20th of April in 2021, this year. And it was given by Professor David Ludwig from Harvard School of Medicine and Harvard School of Public Health. He wears two hats as a professor of pediatrics and professor of nutrition. His talk was the carbohydrate insulin model of obesity. It was done at night. Although it was done at night, we had a very good turnout. Coming up next in this global lecture series is Ben Bigman. He gave us a talk last year and it was very exciting. And so we decided to invite Ben back. And it's on the 31st of July. I think the flyers and the invites have gone out to members. So be a member today and you can listen to Ben and the rest. His title is Contrasting Effects of Ketones and Insulin on Fat Cell Metabolism, or Ketones Metabolic Advantage. Later this year in September, we'll have Professor of Internal Medicine, Mark Kekuzela, and he'll be talking to us on medication reduction, somewhere along the lines of medication reduction, continuous glucose monitoring, and diabetes mellitus type 2 remission. And that's happening on the 24th of September, 2021. And even later this year in November, I'll have my good friend, Prof. Gordon Williams from Harvard Medical School, to be one of our speakers. He always gives very, very good talks and very, very clinically related and yet down to earth science. It's just pure science. And I'm sure the younger generation, the younger scientists among us, and even the mature ones like me, I've always benefited from his talk. We've got our newsletter, and I've always felt that the newsletter of a society is the heartbeat of the society because it keeps the members in touch with what's happening in the society. And I have to express my thanks to Dr. Izzuddin, who is the editor. And it's usually twice a year, but for this year, we decided to have a special issue as the new committee took effect in November and December last year. So thank you, Izzuddin. We've also had the MSPP Young Teachers Award led by Dr. Alima from UITM, and thank you, Alima. The competition was held just recently and the winner will be announced during this meeting. CPD, as I mentioned just now, the next CPD will have, which will give member discount, is peer mentoring workshop, and hopefully they'll take place in October 21st. We had our community outreach talk. And I thought this was pretty special because I'm UCAS, connected with the state government of Malaysia, state government of Selangor, and we gave a talk on food as medicine. And we had a pretty good turnout. We're also initiating a lot of networking initiatives. And MSPP is on social media platform now, so like our FB and follow us on Instagram. I would also like to thank all you general members, committee members, and our national advisors who make the society what it is today. My somewhat tongue-in-cheek comment is in part an acknowledgement of the fact that although these speeches occur year after year, it is the members who provide societal stability. Most of you are unlikely to remember anything about this talk, but I do hope that you will remember your mission as a member of the society and that you work to improve MSPP. Remember that your own work impacts the lives of others. Now I'm going to focus in part on something that most of you might not feel is an exciting bit, and that is a strategic plan. There's a strategic plan for the Malaysian Society of Pharmacology and Physiology. But before that, I think we all know that we are at a critical time in genetics, more so in this pandemic. So many questions are left unanswered. Why are some people more vulnerable than others? Same young age with no known comorbidities, but yet they have different outcomes. Some succumb, others don't. The other important area that I'd like to touch on is the medication errors. Patient safety cuts across all disciplines, and definitely we can help output the education and the awareness out there about medication errors. There's a lot of work to be done, and we need continuity in the work. Hence, we have to step up and build up our undergraduate student chapter in our strategic plan. It is likely, very, very likely, that there are over 1 billion SNPs characterized every day now. The technology advances where you can go from identifying a single SNP and is having some resonance in the scientific community to the scale on which genomics operates today. It's fantastic. It's truly amazing. Now, while we progress very well in fields like genetics, we're not doing so well in avoiding medication errors. We have all suffered under the standards of care of medical community at one point or another. A family member with asthma given a non-selective beta blockers for his hypertension, and that brought on an acute attack of asthma. Another family member got his medication switched, and yet another one who clearly showed that he was having an continuous acute exacerbation of asthma was given only rescue medication, but his maintenance therapy was missing from the drug list, and many more examples. No doubt medication errors aren't intentional. It is definitely a form of neglect, and we cannot afford to let that happen again and again and to anyone. So I urge all medical schools to make patient safety with medication errors as a grand and core focus. It is about lives. Let me provide you with some specifics about our MSPP strategic plan. Now, societies such as ours, which house both physicians and scientists, benefit from periodically focusing on the landscape of their field and reconsidering past mission statements in determining how to best serve their members. At the first EXCO meeting, held soon after the new committee was formed, 3 target areas rose to prominence. The first is to assess the status and likely future of research. Translational medicine, as aptly is the theme for this year's conference, education and advocacy. The second is to ensure that we serve our members and continue to be the leading society in pharmacology and physiology, all the while working with universities and perhaps other societies. The third, finally, is the hardest, and we have to make it a reality somewhere down the line, is to consider goals and strategies for the structure and function of our society in all of its aspects over the next few years, and to begin to think beyond 5 years as well. Personally, and I think my colleagues will agree with me, we are particularly eager for younger members of the society to help us think about how we can make this meeting better for all of us going forward, or for all of you. So remember, please join us today as members. As you can see, we've got a lot of things, a lot of benefits for members, a lot to offer. You can just scan this one. I'll leave it on for a few seconds. With this, I'd like to thank you for listening and enjoy this meeting. Thank you once again. Good morning, everyone. And for some of
Thank you, Prof. Nafeeza, for your presidential remarks. Moving on, I have the pleasure to welcome Professor Dr. Shajahan Yasin, Head of School, Jeffrey Chair, School of Medicine and Health Sciences, Monash University, Malaysia, to give his welcome address. Prof. Dr. Shajahan Yasin is also the Director of Southeast Asia Community Observatory in Johor. Prof. Shah held various training positions, having been chairman of the vocational training program at the Academy of Family Physicians and lectured at Department of Community Medicine and General Practice at Monash University in Clayton. He was also the former Chief Medical Officer to the largest private general practice group in the country. May I invite Prof. Shah Yasin to give his presentation now.
Good morning, everyone, and assalamu alaikum. A special welcome to Prof. Nafeeza, whom I know her when she was the dean and still keep in touch now and then. Also to Prof. Wayne Hodson, for Elizabeth Davies, is our old friends. And of course, a special welcome to this morning's speaker, Professor Gordon Williams, whom I don't have the pleasure of having met before, but the topic seems to be something that will be very interesting, and I'll be sitting and listening to that session. I'm the head of the school here at the Jeffrey Chair School of Medicine at Monash, Malaysia, and I welcome you to this event, Malaysian Society of Pharmacology and Physiology and the 34th scientific meeting. That's quite a long history of meetings in a regular basis. The conference is, as you know, is mainly organized by the Jeffrey Chia School and the Malaysian Society of Physiology and Pharmacology. It is appropriately themed, as I see, as trailblazing the translational research, very appropriate in this time. I'm glad that this collaboration with the society and with a lot of other universities, local and international, is going ahead, and we are constantly looking for working with local as well as regional and international universities in both research as well as education. I'm especially impressed with the registration numbers, which Prof. Nafeeza just showed. 700 participants is no small matter, and nearly 200 posters for abstracts and oral presentations. That is a record, even when we were running non-online, and it does indicate the impressive, it is very impressive, perhaps an indication of the difficulties we are all facing in attending, presenting our research in these trying times, and also an indication of continuing enthusiasm for research discussions and talking to like-minded researchers. I'm particularly impressed by the fact that the conference is so successful in an online format. As we all move into an online teaching, an online format, there is often a sense that we are missing something, but there are something that we are gaining. I don't think speakers from all over the world can come in at low cost and with less disruption to their own work and present and discuss, inform and involve and present their research in that way. There's also this sense that it is for younger people, younger researchers. It is so much easier, so much cheaper, and so much more in terms of time commitment as well. It is also very useful. And so there are advantages which we are slowly beginning to see in online teaching and in the online teaching and online conferences and online sessions. And I'm sure that over time, more and more sessions will go into some form of online sessions, or at the very least, some form of hybrid kind of conferences and workshops where, a substantial amount can be done online and with some face-to-face sessions which are much more focused. I'm also impressed by the fact that this is a free conference, and this, as always, free conferences are only possible by the sponsorships we get, and I would like to thank the sponsors for coming on board and helping us to make this a free conference so that as many people as possible can attend. Thank you for that. Of course, there is huge amount of work involved in developing, organizing something, especially when we are not used to organizing online workshops, conferences on a regular basis. So most of those contributions and work is, of course, voluntary by the members of the organizing committee. There is a large number of people who are involved in the organizing committee, but I will especially like to thank some of the staff who have been very, very critical in making this conference what it is. Some of these include Dr. Alina Brendan, who has been looking after the website and keeping the thing going. And then Lisan for her emceeing. And most of all the other committee members from the various other schools and universities. Thank you for your contribution. I know that you don't get substantial, you don't get paid for this, and you also don't often get as acknowledged for the amount of work that you do. But of course, at the end of the day, I would especially like to thank Associate Professor Farooq, Shaikh, who has been, tirelessly working on this. And he has, he has now become a professional conference organizer. His earlier conference he organized earlier in the year was also a similarly oversubscribed in the way this has been. So I think he does a fantastic job. And again, I'd like to thank him for that. I think I'll leave it as that, and I wish you the best, and I hope you enjoy the conference. I'll be coming in and off on and off to some of the sessions because they look very, very interesting. Thank you all the best, and keep well. Thank you.
Thank you, Prof. Shah, for your welcome note. And now the final speaker for this morning's opening session, Dr. Muhammad Farooq Shaikh, the chair of MSPP 34th Scientific Meeting 2021. Dr. Muhammad Farooq Shaikh is an associate professor of Jeffrey Chia School of Medicine and Health Sciences, Monash University, Malaysia. He is the leader of the Neuropharmacology Research Strength in the school, and he's an adjunct senior research fellow of the Department of Neurosciences in Monash University, Central Clinical School, Australia. He was the regional representative for International League Against Epilepsy, ILAE, and remains an active member of the ILAE Research Advocacy Task Force. He's an active researcher, as evidenced by the number of research awards that he has won, and a commendable teacher. May I now call upon Dr. Farooq Shaikh to present his opening speech.
Thanks, Lisan, for your kind information, kind introduction, and reading out the bio for me. I would like to really thank, first of all, to all the attendees and participants for attending this, conference. I would like to thank especially the Malaysian Society of Pharmacology and Physiology for giving Monash University an opportunity to actually host this 34th scientific meeting of the society. It was supposed to be face-to-face in 2020, along in collaboration with the Malaysian Epilepsy Society. But unfortunately, due to pandemic, we couldn't do that. But I think, again, pandemic has a lot of blessings, and one of them is actually it brings more and more participants from different countries and different walks of life, students, researchers, medical professionals, actually to witness this very important 34th scientific meeting, which, as Prof. Nafeeza and Prof. Shah mentioned about, with the theme trailblazing the translational research. I would also like to thank MSPP and Monash for the initiative to waive the registration fee for all the participants, considering the amount of burden which this pandemic has imposed on all of us, mentally, physically, financially. And I think this given encouragement for students to attain this conference without, students as well as a lot of researchers to attain this meeting without having any financial burden, or whether they are able to actually pay the registration fee. So I think that was the aim by the President, Prof. Nafeeza, and also by the Monash University, Jeffrey Chia School of Medicine. And I think that paid well, where we can see a huge number of participants attending, and as well as submitting abstract for discussing their scientific findings in this meeting. So I hope you will enjoy that. I also, want to give a special thank to our committee members who has done a lot of hard work for you guys to bring this conference live here. And I could not thank anymore to the secretariat, Dr. Alina, Dr. Pejin, and Dr. Alima from UITM. And again, very vibrant and very enthusiastic scientific committee, which is headed by Associate Professor Dr. Sabira Zainal Abidin from UKM, and with other members in the committee, Dr. Chichita, Dr. Tang Kim San, and Dr. Izzuddin. Can you go back to the previous slide, Elena? Yeah. And also our other members, webmaster Brandon, I think Prof. Shah mentioned about him. He's did a tremendous job to bring this website live for everyone. And also our treasurers, Emmeline and Dr. Vinod. Yeah, next slide. I would also like to thank our other committees who has played their part in different aspects. Actually, Without any one of them, this conference could be very difficult. So publication committee team, we have Nita from Monash, then we have Associate Professor Damani from and they will also be doing a lot of work after the conference to put your abstracts together and bring it to the Frontiers publication. Mr. Faiz from Management and Science University. Then our publicity team, Ms. Kong Lisan and Sharifa from UITM and PhD student Ms. Vanessa Lin. I think they have done a tremendous work, and that's the reason we could see about 700 participants here. Again, logistic technical team from Monash, Dr. Shafiq, Gurmeet, and Mr. Ma. They have done a lot of help in bringing this up. And finally, our sponsorship committee. I think we got a little bit of sponsorship, which actually helped to support to make this conference free for all of you. And Dr. Christina, Dr. Vinod, and Associate Professor Tahir were instrumental in bringing that up. So again, thanks for that. I would like to thank our convener, our president of the society, Prof. Nafeeza, and then other chairs, which are Associate Professor Dr. Amuda and Associate Professor Juan Amir from USM for their kind help, and especially our advisors, Prof. Shah, head of Jeffrey Chess School of Medicine, and Prof. Iksan Usman, who is a deputy head of research in Monash University Medical School. So thank you again for that. And I would like to really thank our sponsor, as I mentioned, because of their support, we could bring this conference free for everyone. That's how I think the knowledge and sharing is all about, not really restricting anyone with their ability to pay. But I think this could not happen without the support from our sponsors and publishing partner Frontiers for this. So I thank LabQuip, Straight Scientific, and as well as MC Lab for their sponsorship support. And special thank to the collaborating institution. I think without collaborating, we couldn't bring this big event together, which is UITM, University Malaya, University Kuala Lumpur, and then University of Nottingham, USM, UKM, MSU, and IMU for their partnership to bring this conference along. So I sincerely apologize for anyone for any technical glitch. We understood a lot of you actually probably didn't get email, because I think a lot of emails went into the spam, some of the people. So but we apologize, but we try to share the information on as many as platforms which can reach to you. But again, I sincerely apologize for that technical glitch. We try to resolve that within the next sessions which you'll be attending. I would like to urge everyone to stay safe, take vaccination whenever you get the chance, and also help people who are in need. And at the same time, if we can't help, at least connect the people who can help others. I think this is how we can also overcome this pandemic. So I would like to again welcome everyone, and would like to give my warm regards and hope you will enjoy the next 3 days of this very interesting and important meeting. Thank you so much, and hope you will enjoy the conference.
Thank you, Dr. Farooq, for your opening speech. Let me now invite Prof. Nafeeza and Prof. Shah back on screen to officiate the opening of the Malaysian Society of Pharmacology and Physiology 34th Scientific Meeting.
So Prof. Nafeeza and Prof. Shah, you can initiate the meeting by saying, or you declare it open.
Okay, I'll go.
Prof. Nafeeza, yes, please,
Yeah.
go ahead.
Thank you for that prompt. It is with great pleasure that I declare this conference 34th scientific meeting of MSPP open. And laced with this official opening, I would like to once again express my highest appreciation to Dr. Farooq and his super efficient team. Thank you.
Thank you, Prof. Nafeeza and Prof. Shah for officiating the opening of the 34th Scientific Meeting of the Malaysian Society of Pharmacology and Physiology. Ladies and gentlemen, the opening ceremony is now over. We welcome all to join the keynote lecture now by Prof. Dr. Gordon Harold Williams. This event will be chaired by Prof. Nafeeza.
Good morning, everyone, and a special good evening to Professor Dr. Gordon Williams. Gordon and I have known each other for quite a long time. I read it will take a long time to read his full CV, maybe a week or two. So I will read his brief CV. Professor Dr. Gordon Williams received his BA from Harvard University and MD from Harvard Medical School. He did his internship at the University of Chicago, internal medicine residency and fellowship in endocrinology at the Peter Bent Brigham Hospital, and fellowship with Drs. James and Sylvia Tate at the Worcester Foundation for Experimental Biology. Just hang on. He joined the Harvard Medical School, Peter Bent Brigham Hospital, serving as chief of the hospital endocrine unit, then chief of the endocrine diabetes hypertension division at the Brigham and Women's Hospital, from which he resigned after 29 years. Dr. Williams has been a professor of medicine at Harvard Medical School since 1981 and was a founder and director of its Scholars in Clinical Science program until 2008. He is currently director of the Hormonal Mechanisms of Cardiovascular Injury Laboratory, and Dr. Williams has published an amazing number of original articles, amounting to 600 original articles, reviews, chapters, and books, including co-editing his seminal textbook, Clinical and Translational Research. His research focuses on the genetics of complex diseases involving hormonal mechanisms, specifically hypertension and diabetes mellitus, with a goal to provide personalized or precision medicine for these conditions. His group has used a translational research approach involving studies in humans, animals, and cells with genetic factors linking these techniques. For his genetic studies, he was honored by the American Heart Association as the 200 Lewis Corner Lecturer and the Canadian Hypertension Society as the 2009 President Lecturer. I also know Gordon. Gordon has got a very large family. He's got, I don't know now, Gordon, 26 great-grandchildren or 29 great-grandchildren, but I know he's got a very large family and they're all very close-knit, and how his family means everything to him. And today we will get the opportunity to hear Dr. Williams giving a talk entitled Personalized Medicine, the link between people, animals, and cells. Gordon, the floor is yours.
Thank you very much for the lovely introduction. I always appreciate coming to Malaysia, and I think I participated in one of your earlier annual events several years ago of this society. Today, I'd like to share with you research that's been ongoing in our laboratory for the past 35, 40 years, with the ultimate goal being to determine a way to give personalized medicine to complex diseases like hypertension. And we have used a linkage between people, animal, and cells in our research studies to develop this activity. So here are my conflict of interest statements. None of these consultations, companies I consult with, have anything to do with what I'm going to share with you today. I'm going to start with an old slide. This is a negative feedback loop, probably one of the most important volume homeostatic mechanism in mammals. It involves the renin-angiotensin aldosterone system, but importantly, angiotensin 2 also modifies vascular tone and specifically renal blood flow. By decreasing renal blood flow, just like by increasing aldosterone, salt intake is retained and therefore closes this negative feedback loop. But in contrast to most negative feedback loops that are involved that are two-dimensional, the renin-angiotensin aldosterone negative feedback loop is actually three-dimensional. That is, the environment modifies the level of responsiveness of the target tissues to angiotensin 2, as illustrated here in a human study of more than 40 years ago. Here, their angiotensin dose response curve, and you can see aldosterone is measured, but notice that the level of aldosterone that is produced by a particular dose of angiotensin 2 depends on the level of salt intake. If it's low, it's much higher than if it's high. So therefore, if there's derangement in this negative feedback loop relationship to target organ responses, you might anticipate that disease would occur. And yes, it is. In hypertension, individuals who have difficulty with salt sensitivity of their blood pressure, some of these individuals, they do not show this dietary sodium-mediated responsiveness to the level of salt intake, as you can see here. And these individuals are called non-modulating hypertensives, and you can identify them by the response of the renal vasculature, the adrenal to angiotensin 2. One group of them have very low responses, quite abnormal. This is what a normal response would be in response, while other people with hypertension will have a perfectly normal response. This red subgroup are non-modulating hypertensive individuals. And they had some interesting other characteristics. Among them was what appeared to be a genetic component to it, because the group in red would, about 75–80% of them would have a family history of hypertension, while these hypertensive individuals, it was only about 20–25%. So I was asked to attend a meeting in Salt Lake City to discuss these non-modulating hypertensive people with genetic experts at the University of Utah. But at the same time period that I was to meet with them, I had an interesting patient that I saw. And this patient was a truck driver. He had very uncontrolled hypertension. And so I did what you normally do with hypertension patients. You work them up first for secondary causes. He had none. And then I started him on an antihypertensive drug. A month later, he came back, not much change. I changed his drug to another drug. This went on back and forth for about a year, maybe a little more than a year, and with probably 5 or 6 changes in drugs. So about a year after this, my first introduction to him, he came in and said to me right across the exam table, he said, "Doc, I don't think you know what you're doing." Well, after I got over the shock of this, as any physician would, he said, "I think you're playing Russian roulette with me. That is, you will try something. If it works, fine. If it doesn't, to lower my blood pressure, you'll try something else. you'll mix and match and you'll try to get a right combination to make it work. And then he did drew a very interesting analogy. He said, why can't you do what you did with my urinary tract infection some 6 months ago? And that is, you took a urine specimen, they did something with it, and you said it was a culture, and then they tested the sensitivity of your bug with different antibiotics, and you knew exactly what drugs that I ought to use to treat my urinary tract infection. So why can't you do that with hypertension? So with this background, I went to Salt Lake to present the non-modulating story. Roger Williams and his group were the group who were doing genetics of cardiovascular disease, but not particularly hypertension, except for Jean-Marc. And after I gave my presentation, Roger and Paul Hopkins both said, well, why don't you look for the genes variations in your cohort and see if you can identify a particular gene or a couple of genes that might explain the differences in those who respond normally to Ang2 versus those who do not. And that started us to look at a different way of evaluating how people have hypertension that may lead us to giving precision information. You see, there are also two individuals from Paris who happened to be there at the same time, Pierre Corveau and Xavier Jeanmet. So our overall research goal from that time was to determine the genetic underpinnings of hormonal and renal mechanisms of cardiovascular risk, with a focus on hypertension and diabetes. And the basic genetics, this is what we had planned to do. You can see we were going to grab the DNA, measure the genotype of the individual, hopefully link that to the most proximate phenotype, that is approximate one, which is usually biochemistry. And that we would identify by determining the intermediate phenotype of the individual. And then we would to get the intermediate type, the individual would have to have the distant phenotype. And I've illustrated that just with brown hair. So hair is the distant phenotype. If it's brown versus blonde or black, it's a intermediate phenotype, and that would be linked to a protein that led to the brown pigmentation that you see in the hair, which would be linked to certain genes that would be different. The expression would be different if you had brown hair as opposed to blonde or redheads and so forth. So about about a year or two later, when I was at a meeting in Austria concerning genetics and hypertension, most of the individuals who were there, this was right after the human genome was described, most of the individuals who were there had been looking at purebred monogenetic forms of hypertension in rodents. And we had as a speaker, Twilliger, who had published this particular statement relative to the human genome. And the critical part was, he said a SNP, that's a variation in a particular gene, obviously, is not the same as a disease predisposing allele. Much of the enthusiasm for functional genomics may be illusionary in ways similar to sequence-based approaches. He said, this is not an argument against genetics, but for revised genetics, the interface is more intimately with biology. In other words, he was chiding us by spending an enormous amount of time thinking about the gene and not very much time thinking about the phenotype, which may be more critically important in terms of trying to figure out what's going to help the individual with hypertension. And he illustrated that by his comment about the New York City sewer rat. he said, I've heard several studies here where there was a clear-cut analysis of a single gene change in a rodent that led to a particular phenotype, in your case, salt sensitivity or blood pressure. But that's not what the humans are. The humans are not those purebred individuals with monogenetic defects. They're more like the New York City sewer rat, which is very heterogeneous in terms of its phenotype. So you need to concentrate more on the phenotype. And if you go back many years to Mendel, when all of this started, even before the word genetics came around, he in essence was saying the same thing, particularly if you read the second bullet. The first bullet gives you the background relative to the second bullet. And what he said is the characters, meaning the phenotype, do not permit sharp and certain separation, since the differences of the more or less nature, the differences of the phenotype are often difficult to define. So that fits right into what's happened over the last 10 or 12 years relative to precision medicine. And of course, this is a model that's going to allow us to be much more specific, like my truck driver wants us to be, in treating complex diseases like hypertension, the same way at one level as what you do with a urinary tract infection. And it advocates to overcome the deficiencies of the present algorithm-driven approaches to treat these diseases. And there are two contrasting approaches, but not necessarily conflicting. One is using big data, and the other one is deep phenotyping. I'm not going to discuss the big data approach, but you're probably well aware of it because it's been present for most of the 21st century. That is collecting large amounts of clinical data, doing sophisticated genotype and computer analysis to link the clinical data, the phenotype, to the genetic alterations, but has had difficulty because of the heterogeneity of the phenotype. It's structured to have great deal of emphasis on perfecting the genotype and looking at the distant phenotype, the elevated blood pressure, or blood pressure alone as the phenotype, without having to go through these two steps to actually make it more, make it easier to actually produce this linkage. The big data approach is somewhat different with the same philosophy, but using the whole spectrum. It creates a three-step paradigm to achieve specific individualized therapy. And what it does, it identifies specific mechanisms of the individual diseases. And its underpinning is, compared to big data in part, it arrives at the conclusion that chronic illnesses are really not diseases, but syndromes of a collection of individual diseases. What we call diseases, in other words, hypertension, diabetes, anxiety, depression, are really only symptoms or signs of underlying diseases. And what we need to do is to determine what the underlying subsets or diseases are for each of these. And the way to do that, you have to have two types of phenotypic correlation. First is it's in a translational research structure. And that is, you have to have deep phenotyping of a controlled human cohort. And from that information, then design an animal preclinical studies that modify the genes in them to see if their phenotype is the same as what you see in the human cohort. And if you can do that, that is, identify from the animal studies the mechanisms underlying the individual diseases, then you can use the genotype, which isn't going to change in almost all cases, with environmental influences, to identify the specific person with that particular form of hypertension, for example. And then from your knowing the mechanisms, you'll be able to identify the precise treatment prevention strategy for that particular subset of hypertension. And that's the contrast between the big data and the deep phenotyping. They actually complement each other depending on how you want to use them. But this may be a better way to do the discovery part of it, although albeit very expensive because of development of the human cohort. So this approach actually uses all three types of phenotype. It's primarily geared to look at intermediate phenotypes, and by understanding enough of the physiology behind the intermediate phenotypes, it will then potentially be able to at least suggest proximate phenotypes in the humans, but in the animals and cells, you'll be able to find the specific mechanism involved in these individuals with this genotype. So it's easy to start with hypertension because a change in blood pressure has to be secondary to a volume change or a resistance change in the vessels. And we've known that for a long time because of the fact hypertensive population can be divided into salt-resistant hypertensives or salt-sensitive hypertensive individuals. And but the problem has been the difficulty of having a pure phenotype that you could rely on leaking mechanism to gene in these individuals, because the environment plays such a major role in changing what you might be measuring in these human individuals. So with help from NIH, HyperPath cohort was developed. It was started in 1996, now has about 2,200 study subjects. And its role was to characterize genotype-phenotype correlation with a specific emphasis on salt sensitivity of blood pressure by what happens when you change salt intake. The original cohorts were, as you might anticipate from my trip to Utah, Boston, and Paris, France. I won't go through the specific protocol. You can read it here, but primarily it gets rid of all factors that you think might influence any of the volume homeostatic mechanisms that have been identified both in humans and animals over the previous 50 or 60 years. And then what it does, it specifically manipulates the salt intake, a high salt diet, liberal salt diet for all practical purposes, what we eat every day, and then a low salt diet, and measure the responses of these homeostatic mechanisms to determine are there different phenotypes that can be identified, like I showed you on the previous slide. So over the last decade and a half, we've been able to identify 10 mechanistic intermediate phenotypes with genetic biomarkers. Because the cohort is developed around salt sensitivity, clearly most of them are in the salt sensitive group, with only one have been identified in the salt resistant group. But interestingly, in the salt sensitive group, you could have ones that are associated with a low renin level or with a normal renin level, maybe even an elevated renin level, because their salt sensitivity is something that's not related necessarily to aldosterone, but related, excuse me, to other factors like renal factors that lead to an increase in salt retention. Now, I don't have time today to go through all of these to illustrate the approach that was used. They're actually summarized in part in a review article in Endocrine Reviews published a couple of years ago. But for the purposes of today's discussion, to show you the translational research approach, I will illustrate this with lysine-specific demethylase 1, a gene that most of you may not have heard of unless you're involved in oncology, where it has been extensively studied. And let me tell you a little bit about this particular gene, because the moral of it is that animal models can be very revealing for mechanisms when you're not sure how that's going to work. And therefore, never stop looking. What you know may not be all that you need to know. And this is illustrated by LSD1. It's the first known histone demethylase, and it was discovered by Shi, who worked as a postdoc in a lab of Dr. Shi in the Quadrangle at Harvard Medical School in 2004. And over the years, it's been documented that one of its primary function is it's an epigenetic regulator of gene transcription. So it works on the histone, as illustrated by the first bullet here. And by changes in the histone, it then causes modification, regulation of chromatin structure and gene expression. In essence, what happens when you change, when you demethylate the certain areas that it can work, it either tightens the coil or loosens the coil. Loosening the coil makes it easier for other factors to get into the genome in order to modify gene transcription. Interestingly enough, its epigenetic effect is clearly illustrated by the fact that it is modified itself by changes in the environment, namely changes in salt intake, as well as changes in caloric intake will modify the level of LSD1. The hyperpath cohort study was performed that looked at polymorphic variants in the LSD1 gene and the relationship to salt sensitivity and blood pressure. And so from that cohort, one of the SNPs, RS567168, showed that if you were the minor allele carrier, you have salt sensitivity of blood pressure, increased systolic blood pressure when you change the salt intake, compared to individuals who are the wild type or the major allele homozygotes. But importantly, only in those of African descent and maybe Hispanics from Mexico will show this phenomenon. Well, when we saw this, we assumed that maybe aldosterone was involved, because you would think if you have too much aldosterone, you might see the same effect. And maybe LSD1 was dysregulating aldosterone's effect. So aldosterone was measured, and lo and behold, it was not what we thought it would be. You can see they have low aldosterone levels on the liberal salt diet compared to the wild type or those with the homozygote for the major allele. So that suggested that the blood pressure was actually due to an interplay between LSD1 and vascular function, specifically on the high salt diet, which rather than an aldosterone-mediated event. This illustrates the dose response curve, gene dose response curve in response to these phenotypes that I've just shown you. Here's the salt sensitivity of blood pressure. You can see it goes up when you get to from the homozygote major allele to the homozygote minor allele. The aldosterone levels go down in the opposite direction, as I showed you. But paradoxically, you can see that paradoxically, the potassium was not following the aldosterone as you would anticipate. Because when you have too much potassium excreted and salt sensitivity of blood pressure, you would assume that it was secondary to the potassium loss and the blood pressure was secondary to an increase in aldosterone. But instead, you were having a decrease in aldosterone. So let's go back to the animal lab then. And Gino Shi had developed developed an animal model with a heterozygote knockout of LSD1. And this animal model had its interesting physiology comparable to what we saw in the humans. Here's systolic blood pressure. The wild type in blue and the pink were the LSD1 heterozygote. On the low salt diet, you can see they're the same. But on the high salt diet, you can see there's a significant increase in blood pressure if you have the LSD1 heterozygote. That is, they have salt sensitivity of blood pressure, which is similar to what you saw in the humans. And furthermore, like the humans, these are plasma aldosterone and urine aldosterone. You can see the LSD1 heterozygotes have lower aldosterone levels than do the wild type animals in this cohort study. Now the rest of the story. Remember that what I illustrated here was in individuals, mice that are 100-week-old. This is what happens if you look at their adrenal glands and their 15 to 20-week-old mice. These are isolated glomerulosis cells studies. And these are LSD1, normal LSD1 individuals. These are LSD1 heterozygote. Control Ang2 stimulated cells, ACTH, and potassium stimulated. And this is the aldosterone output. On the low salt diet, well, they don't look any different. The two groups look very similar, whether they're on, if they're on a low salt diet. But notice what happens if they're on a high salt diet or liberal salt diet. The LSD1 the homozygote major allele, they suppress everything, just like I showed you previously, compared to what would happen on the low salt diet. So that's what you would anticipate. But the heterozygote knockout animals, they don't do that. So their high salt diet aldosterone response is essentially unchanged to what it was on the low salt diet. So in the high salt diet, they're producing too much aldosterone, which clearly would lead to hypertension. But we can't find elevated levels of aldosterone in our 100-week-old mice or in the humans who carry the risk allele. So what's going on here? So here's a study to address that. These are taking 36-week-old mice now, wild type and LSD1 heterozygotes, high salt diet as a part of the run-in, and then randomized for 2 weeks with either a placebo or a pleromone being a blocker of the mineralocorticoid receptor. And then kidney tissue, blood, and urine was looked at, and blood pressures were measured in these individuals. Well, here's your systolic blood pressure on the liberal salt diet. And as you can see, the heterozygotes have much higher blood pressure than the homozygote minor allele ones are. And now what happens when you give them a pleromone? It all goes down. Doesn't change anything in the placebo group, but you can see you have a substantial reduction of blood pressure in the individuals, the mice that are heterozygote. It decreases their blood pressure, suggesting that in some way aldosterone may be involved in this, because blocking the mineralocorticoid receptor reduces it. Now, what about your urine potassium that I mentioned to you before? Elevated at the beginning, but when you treat it with the pleromone, goes away. So it's no different between the wild type and the heterozygote knockout when you treat them with a pleromone, again suggesting more aldosterone-like activity, but what about the plasma aldosterone levels? And they're down. So they're not like their 15 to 20-week-old counterparts. They're more like their 100-week-old counterparts. That is, their aldosterone levels are down. Now, what could cause their aldosterone levels to be down at the same time they act like they have too much aldosterone? So the answer was related to what aldosterone interacts with, the mineralocorticoid receptor. Because as you can see, the mineralocorticoid receptor expression level is twice as high in the kidney of the heterozygote knockouts than in wild type animals here. And not only is the mineralocorticoid receptor higher, but also a downstream readout of an ENAT, its expression is also about twice as high as the wild type in the face of a markedly decreased expression level of LSD1 in the kidneys. So it appears as if that instead of aldosterone being the villain as the animals age, the mineralocorticoid receptor has then been activated more, or its expression has been increased. And with that increased expression, it is doing the same thing that you would see if you had increased aldosterone levels relative to a aldo-MR mediated pathophysiologic process when you knock down the heterozygote model. So that then led to a study to see what happens when you look at salt intake in the heterozygote knockout mice versus the wild type. So this is the systolic blood pressure in male LSD1 wild type and LSD1 heterozygote. They're treated beginning at 16 weeks of age with a liberal salt diet for approximately 50 weeks. And blood pressures are measured, as you can see. They start to go up even in a wild type after about 5 months of treatment with the liberal salt diet. But clearly, if you look at the heterozygotes, the change in blood pressure is much more significant than the Trajan blood pressure that you see in the wild type animals. Not only is the blood pressure up, but also their kidney function is decreased. This is microalbumin creatinine ratio. Here you can see there's a modest change in the heterozygote wild type animals, but notice the homozygote carriers, they all go up pretty consistently after the first month of treatment with the liberal salt diet. Well, this is very interesting because maybe either the blood pressure going up or something related to aldo or something related to other factors could be suppressing the aldo levels, but the whole process then being orchestrated by the change in the mineralocorticoid receptor. Well, these are in males, so the logical step is, does the same thing occur in females? And is this therefore homogeneous regardless of sex? And the answer is no. Here's the systolic blood pressure over the same period of time in wild type and heterozygote knockout. And you can see there's absolutely no difference in their blood pressure, whether they're on a low salt diet or whether they're on a high salt diet. There's absolutely no difference. Female heterozygote mice do not show a salt sensitivity or blood pressure like you see with the males. The question is, do you see the same thing in humans or something similar like that in humans? So there's one study that we've done to address this, and this is taking humans with of African descent that are middle-aged or less, and we're measuring their aldosterone response to angiotensin II, what sex they're on, and also what their level of aldosterone might be in response to angiotensin II. And you can see that wild type or normal humans, the females have a lot more aldosterone than the males do in response to Ang2. But if you're a heterozygote knockout, I mean, if you're a risk allele carrier, you see the opposite effect. That is, the males are higher, but for all practical purposes, there's not much of a dose of a change in what the level of aldosterone is in response to the angiotensin II with this. So let me summarize what I've been talking about. LSD1, an epigenetic regulator of gene transcription, modified by salt intake. Deficiency in young LSD1 males and females result in dysregulation of aldosterone synthesis and increased aldo on a liberal salt diet. Over time, LSD1 deficiency results in salt sensitivity of blood pressure in both mice and humans, and eventually hypertension. Over time, LSD1 deficiency in mice and humans results in salt sensitivity of blood pressure despite reduction in aldosterone levels. Middle-aged mice that are LSD1 deficient have low aldo levels, have salt sensitivity of blood pressure, and biochemical evidence of hyperaldosteronism. Normalized aldosterone phenotype when a mineralocorticoid receptor antagonist is given. And associated with that is increased MR expression, the mineralocorticoid expression, at least in the kidney. Male LSD1 mice with age increased liberal salt blood pressure and microalbumin. Females do not do this. Significant sex LSD1 genotype interaction occurs in mice. The data that I didn't show you in the various steps in the aldosterone biosynthetic pathway. And significant sex LSD1 genotype interactions in middle-aged younger humans for aldosterone, but I didn't show you this data, but not for older individuals, are salt sensitivity of blood pressure. Estrogen inhibits MR-mediated gene expression as one of the mechanisms potentially causing this difference, since the female mice still have plenty of estrogen around even after 60 weeks of age, which would not occur in humans. So the schematic would be LSD1 deficiency on a liberal salt diet leads to increased aldo, and then with increased age in females or males, salt sensitivity of blood pressure occurs in the males, but not in the females. But if you have estrogen deficiency, then salt sensitivity in the females, then salt sensitivity of blood pressure also occurs in the males, leading to decreased aldosterone, increased MR, and hypertension. So as I said earlier, our overall research goals is to determine the genetic underpinnings of hormonal and renal mechanism of cardiovascular risk with a focus on diabetes and hypertension. Why did it have this type of focus? Because ultimately, what you want to do is this. Precision medicine is structured so that when you do a clinical trial, one of the products, in this case, a eplerenone, which would be the potential target for the LSD1 mediated hypertension, versus amlodipine, a non-specific antihypertensive, would over the course of 4 weeks result in a reduction in blood pressure versus minimal reduction in blood pressure at this earlier time point. And this is a classical clinical trial design driven by genes to determine, can you have the personalized medicine as my truck driver very much wanted to have occur. These are the team that's been doing all of these works over the last year, particularly Lumi Pajoga and Jonathan Williams have been doing the LSD1 studies, but all of the rest of them are involved in different studies. These are the worker bees who are doing it. Some of them have come from Malaysia. The top part are individuals in our clinical genetics group, and the bottom part are the lab individuals who did some of the laboratory studies. These are many people that we've collaborated with at the faculty level. And these are the fellows and students who have been part of these studies at one level or another over the last 30 or 35 years. And finally, and importantly, you need to maintain work-life balance. This is our family about 4 years ago, 4.5 years ago. Thank you very much for your attention. I'd be happy to answer any questions.
Thank you, Professor Williams. Brilliant as usual. Prof William will say he will take a question, some questions, but I think we have got time only for one question. So anyone from the audience, please raise your hand. But otherwise, I have two things to say, Prof Williams. One is a comment and the second one is a request. Number one, I have always been amazed at how immersed you are in basic science. And you're probably the only clinician that I know who does that. You know what goes on in the lab and you take it back to the bedside, and it's also amazing. And I can never forget the time when in UITM you showed us the clot that was happening somewhere. I can't even remember it. Close to you, I think in Malaysia would be my two mentors, which is the late Datuk Khalid Yusof and Datuk Khalid Khadir, who is also in Monash. They are the two clinicians who come close to you and know the basic science. Number two is a request, Gordon, if you may. Most of us here, although it's an international conference, international participants, I think a lot of us here are Malaysians. So can you tell us about your findings on Malaysian? Are we salt sensitive or resistant?
Oh, well, as you might anticipate, the population in Malaysia is different than the population that we have in the United States or in Europe in terms of their genetic underpinnings. To illustrate that, I involved in a study with BP Ho, who's a professor at UCSI. And so he looked at the population that he had in Malaysia in terms of that chart that I showed, the 10 different forms of salt sensitivity hypertension linked to specific genes. And one of them that I mentioned at the very beginning of my talk, that is one that's driven by polymorphic variants in the angiotensinogen gene. There's no evidence for that in the Malaysian population, whereas in the European American population, it's about 25% of the people carry that risk, have hypertension. Now, the reason for that is that the risk allele for that, the risk allele for angiotensinogen that drives that particular phenotype is present in about 96% of the Malay population. So therefore, there's no large enough control group that you can see any effect relative to that particular phenotype. The interesting corollary for that, he then went on to look at the relationship to the presence of that phenotype depending on how far away the population is from the equator. And the Malay population has a response, has a frequency of the risk allele carriers that's about the same as the African population. Very different than what you see in a European population, particularly in a Northern European population. So when everyone does these types of genetic studies, you have to make sure that you know what the baseline level of the risk alleles that you're looking for are in that particular population.
Thank you, Prof. Williams. I think it's past 10 o'clock and we should be ending at 10. So I would like to invite everyone to thank Professor Williams in our usual way. We can't hear the applause, so I'll applause. Thank you, Gordon. Thank you. Over back to Emcee.
Yeah, we are now going for our break now.